So today we've been dispatched to a residential address for a 70-year-old male with acute chest pain. His wife's met us at the house and she's described to us that he's a sudden onset of chest pain with some associated dizziness while standing, and that he's also felt some palpitations. So we've assessed our patient. We've found that Frank's unable to obey command, so he's got a lowered level of consciousness. He's also very pale and clammy. We've done a set of vitals, found that he's got a broad complex tachycardia at about 170 beats per minute. He's got a rest rate of 18. He has blood pressure of 70/40, so he's quite hypertensive. We've also done a BGR to make sure that's not the reason for his lower level of consciousness, which is fine at 7.6. And we've also done a temperature and looking for any signs of infection that could be causing him to be this way, but that was fine too at 37, and there's no signs of infection that we can see. We're going to complete a 12 lead because of his broad complex tachycardia, and we can consider giving him aspirin, but he's unable to obey commands and will be unlikely to be able to chew the tablet. This is the 12 lead that we've gained from Frank. There's a broad complex tachycardia obvious there. We're suspecting that it's VT. We can see that there's capture and infusion beats present as well, which leads more likely to the diagnosis of VT, along with the fact that he's had a previous MI about 5 years ago. There's no left bundle branch block or right bundle branch block morphology present, and there's precordial concordance, which suggests to us that it's more likely to be VT than SVT with aberrancy. We've also looked for signs of infection, which we couldn't find any of, and we're also considering there might be an electrolyte imbalance, possibly. However, because he's got a low blood pressure, he's hypertensive, he's quite pale and clammy, and he's unable to obey commands, he's severely compromised, and we're treating as for VT, and we're going to cardiovert him. So we've determined that our patient is in VT, he's severely compromised, and he's status 1. We've called for an R50, and while 50 is en route, we're going to cardiovert. We've gained IV access, however we don't need to sedate our patient because he's currently unable to obey commands. But we're going to prepare for cardioversion, and we're going to use the checklist within our pocket CPGs. Alrighty, first thing we want to do is allow our patient supine. And we're going to attach the defibrillator pads. These are going to be in the apex and sternal position. So we can see our broad complex tachycardia. We're going to turn the defibrillator to manual mode, making sure that it's at max joules, which is 360. So that's the joule we want for an adult. We're then going to synchronise it. So to do this, we need to make sure that we've got a lead with a good QRS complex. And we'll also make sure that we've got no artefacts. Artefacts suggest that it's poor lead placement. So this gives us a good view. We're then going to select this lead. We're going to sync it. We can print out a strip here to see that there's detection symbols at every single QRS complex. There we go. And that's evident on the screen as well. We don't need to sedate our patient as he's already unable to obey commands. So now we're ready to cardiovert our patient, but before we do so, we're going to just check our cardioversion checklist, make sure we've ticked off all the points before we do so. So he's in VT, we've got the defibrillator pads attached in the sternal and apex positions. Our monitor is in manual mode, and the lead with the tallest R wave selected, there's no artefact. We've got detection symbols above every QRS complex, and it's in sync mode. We don't need to sedate him because he's still unable to obey commands, and we're selected up to maximum joules. So what we're going to do is we're going to cardiovert him, so we're going to charge up. So we're charging up to 360 joules. Right, everybody clear? Shocking. So now that he's been cardioverted, what we want to do is we want to reassess his rhythm, see if he's still in VT, and we want to reassess his level of compromise. If he's still in VT and he requires a second cardioversion, we need to make sure that the monitor's still in manual mode, that it's still synced to the right lead, and that we can cardiovert again. If not, then we want to extradite and we want to transport off to hospital. We've been dispatched to a residential address and found a 40-year-old male lying supine on the ground. His elderly neighbour states that she saw him up water blasting on the roof earlier today. It appears as though he's fallen 6 metres from the top of the roof down to concrete. On assessing our patient, we found that he has an altered level of consciousness, has GCS of 5, made up of 1, 2 and 2, because he's extending and he's moaning and growing into pain. He's got a heart rate of 50, he's got a rest rate of 12 with slow, irregular breaths, and he's also grunting. We've done a BGR to rule out hypoglycemia, which was 7.6, so that's within normal range, and his temperature is 37. His blood pressure is 160/90. We've done a rapid trauma sweep and found that he's got evidence of injury to his posterior aspect of his head with a crepitus and some spongy spots. So with this in mind, we're going to treat him as for TBI. Now RSI is indicated for patients with a lower GCS less than 10 and a clinically significant airway or ventilatory compromise, which he has with his grunting and his irregular rests. So we're going to call for an R50 for an RSI capable officer. We've called for them and they're 10 minutes away. So while they're en route, we're going to use our pocket CPGs and set up for RSI using the RSI checklist. So the first thing we want to do is pre-oxygenate our patient. We can do this using a non-rebreather mask at 10 litres of oxygen per minute, or we can use a bag valve mask at 10 to 15 litres per minute. I'm also going to insert an OPA to see if he tolerates it and just to keep his airway open, which he does. So the reason I'm using a bag valve mask is to assist his ventilations. I'm also using PEEP attached, and that's at 5 centimetres due to his TBI. I'm also going to set up for capnography. This needs to be attached to the monitor a little bit forward to let it calibrate. What I also want to do is I want to attach nasal prongs. These aren't going to be connected up to the oxygen just yet, but they're going to sit underneath the bag valve mask, and they're going to allow for passive oxygenation during laryngoscopy. So my offside is going to continue oxygenating my patient, and while they're doing that, I'm going to make sure that they're all set up with assessment. So I'll put the NIBP cuff on, the ECG leads are attached, and the SpO2 probe needs to go on. Once that's all done, I'm going to make sure that the monitor's where it can be seen, but I'm going to make sure that there's enough space off to here for the airway gear, off to the right side of the head. The capnography has been attached to the defibrillator, and that's all ready to go. So we've gained IV access with a 16 gauge in this arm. It's patent. We're going to gain in that arm too because we want bilateral large bore IV access. We're also priming up a bag of fluids so that we can run that through. So we're going to continue to pre-oxygenate our patient. We also want to make sure that he's in a good position for airway management. So this is going to involve just placing a towel or something underneath his head until we've got good alignment, which we have there. We also want to prepare by putting a Thomas tube holder underneath his neck. We're going to leave it undone, but just so that it's there for when we need it. Our suction's nearby. We've checked it and we've turned it off, waiting for in case we need it. We want to clear the area up before the officer comes so we've got good access to both sides of the patient. And we want to do another set of vitals so that we can update our RS officer saying that he is still status 1, his GCS is still 5, and that his condition hasn't changed. We can also consider administering morphine, particularly if it becomes very competitive, but at this stage we don't need to administer that. So prior to RSI, we want to have discussion with the RSI officer about what to do in the case of a failed intubation. This may be in the form of trying again with a bougie for another intubation, it may be in the form of basic airway management, or we may move to a crike. We also want to have a look just before he gets here about whether or not we can extricate a lead. We've got quite a difficult extrication at the site, so that's not really an option, and that's why we've stayed and decided to RSI where we are.